Hey, CC.
Hey, Dr. Abrams.
Did you know that Dr. Winslow was sick?
I knew he was sick for a bit, not very long though. I knew he was sick like maybe about a month ago.
I noticed about, I think it's the meeting before last,
The PVR one, yeah.
He had a dermatitis, and it crossed my mind that maybe he was on a MAB of some kind.
I didn't even think about that. I
didn't say anything or anybody. I thought it was, he had either gotten a bad sunburn or else he was on a MAB. And I didn't figure he had been out in the sun that much. So
I didn't realize that was a common thing with the chemos. The skin lesions it's common with the MABs.
Yeah, that's common. They get autoimmune dermatitis thing with it. But what a wonderful man. What an amazing role model he was for the residents there at in your program.
Yeah, I mean, I was telling
Just
John, I wasn't really thinking retina until he kind of pushed me towards retina. And initially, I wasn't actually sold on retina.
Very interesting.
Yeah.
Well, he just he touched a lot of lives. He was just what a terrific, and you're telling me about the wind stuff. That was just so funny and so nice that he did those things for the resident group there.
Yeah. So what we were saying for the fellows, actually, Dr. Winslow passed away yesterday. He was my mentor from residency. I know he joined a few of our surgical conferences before. The last one was back in September last year on PVR. I was actually just looking at that video. I was just watching that video, the PVR surgical conference.
I'm sorry to hear that. Yeah, I met him first at the fellowship interview at UD, and everyone, all the fellow candidates couldn't stop talking about how much they enjoy talking with. And yeah, it was really a treat having him on these surgical conferences lately. Sorry to hear that.
He always had a lot of wisdom.
Yeah.
Yeah, definitely.
So today I figured before I usually give Ingrid to send it out, but I didn't realize Ingrid was out, so I had to do this kind of last minute. I don't think we're gonna have a huge audience today, but that's okay because some of these topics are kind of on the fellow level anyways. But I think we'll just go ahead and show videos. Sorry, I didn't put together a slide this time, but I have some videos. But everyone else goes.
If Deepa and Chris are going to be able to.
I haven't heard from Deepa. Have we heard anything from Chapman?
When I was in the OR with Chapman this morning, he said he would see me tonight. He'll be here.
Okay. Well, let's give him a couple of minutes then. I'll let him know too.
We'll get my cup of coffee.
I'm gonna make someone else the host real quick, because I'm gonna try to reconnect my internet. Seems a little laggy on my side. Hey, I'm gonna restart my my router real quick. I think my internet's a little laggy. I don't know.
Oh, no cell phone signal, no internet.
I thought it was me. I'm just glad it wasn't me.
Now they just left the fellows alone. Chaos can ensue.
Did your router reboot yet, Dr. Lin? Or are you off your phone?
I think it rebooted. So far, no one's lagging. You wanna
Yeah.
you wanna get started, or who? I
I
guess
think we all have videos.
everyone has videos. Okay, we can just. Well, why don't you just get started, Anthony?
Yeah, sure. Since I'm already co-host here, I'll share my screen. I guess my case is somewhat straightforward, so probably a good case to start with. It's a Yamani technique, which we've seen before. This was one I did with you, Dr. Lin, earlier in my first year. Let's see, I'll share the screen. But it also has something else kind of interesting about it. So I assume everyone can see this. So this was a guy, I think he was about 64 years old. He presented to walk-in clinic with new photophobia, a little bit of redness. He had a remote history of intraocular surgery. He wasn't really sure what the surgery was for. He's a pretty poor historian, but had presented with this new symptom after a recent trauma. But vision loss wasn't really his main complaint. It was more the pain. So that brings a question of chronicity of kind of the finding we saw, which was that he did have an iritis, possibly traumatic iritis, but then we also noted him to have a subluxated crystalline lens. So after his inflammation had quieted down, we took him to the OR. And I'll show it a little clearer later on in the video, but he had this very interesting pattern of pigmentary changes and atrophy. You can kind of see it extending. So here's the nerve. I'm not sure if my cursor is visible, but the nerve is on the left hand of the screen. Macula is just to the right of that. And you can see these kind of arcuate patterns of chorioretinal atrophy with a little bit of a yellowish appearance, more towards the central macula. It's kind of relatively spared the what looked to be, the foveal region. And you can see in the lower half of the screen, the crystalline lens is, markedly out of position, basically freely hanging back, just a few zonules, probably a clock hour or so of zonules still holding. So I thought that pattern was really interesting. I suppose, he has this remote history of intraocular surgery. We don't really know what it was. He didn't seem to be vitrectomized, but, I guess an RD could have given that if it's, since resolved. But again, he didn't seem to be vitrectomized, didn't really have a buckle in place. I was thinking the lens could have just abraded, basically mechanically caused over some time, perhaps years, caused kind of this, it's almost like a snow angel kind of type of pattern of RPE changes. So it'll be a little clearer later in the video, but it was really striking kind of when we first saw it. With the cutter, saw that the lens was pretty dense, so elected to use the fragmatome, and were able to more efficiently take out the rest of the lens. This part isn't too interesting, so I can kind of fast forward that.
Since we're talking about the fragmentome, I know it's kind of basic, but I'm not sure we actually talked about it. What we normally do for the fragmentome wound. What I typically do is either at straight temporal or superior, I make a small peritomy, and then I mark probably about 2.5 to 3 millimeters, probably around 3 millimeters from the limbus, and go in with the MVR blade. And the key when I do it is the MVR blade goes sideways. It does not front and back, just because you're putting in a large frag that potentially it can extend the wound a little bit. And if the wound is going, radially, you can potentially, theoretically, can extend into the retina if you're with a big instrument. So that's what I typically do. You have to make it. I go in with the 1 millimeter MVR blade or 1 millimeter side port or MVR blade. Generally, you have to enlarge it just a little bit. And then with your frag, you want to test it outside the eye first, because you have a couple steps. You have one where it's just aspiration, and then you once you kick it into the next level, it's fragging. And the key with these ultrasound energy is the energy comes all the way around. There's a ball of energy around the tip of the ultrasound. So in a cutter, you could turn the cutter away from the retina and you can still cut, but in the frag, you don't want to frag anywhere near the retina, just because there's a ball of energy even on the side away from the port. So you always want to make sure you know where the foot lever is, or the foot positioning, because anything when you're doing close to the retina, you want to make sure you're just on aspiration, and then bring it back to the mid vitreous for fragging.
The retina doesn't take well to being fragged.
Yeah.
I saw a patient one time that he came to me after he had had a removal of a dislocated crystalline lens, and they had accidentally fragged his retina, and they had taken out his whole macula. I mean, it was pretty ugly.
You know that thing they were doing that Bausch and Lomb was playing with, using like basically ultrasound to cut the vitreous. They have like they call it a Vitesse. That's their brand name. Name. Basically, it's like an ultrasound retractor. Well, the interesting with that is, and I tried it in their wet lab. That thing cuts through retina like no other. So they have a port on one side, just like our vitrectomy, but the other side will cut right through the retina too.
So forget about using it for TRD dissection or anything like that.
No, you couldn't. Absolutely couldn't.
Yeah, you can.
I mean, really about all it's good for is
core vitrectomy.
cord vitrectomy.
So unlikely to catch on, it sounds like.
Dr. Abrams, how far out do you put your frag? I always put it around 3 millimeters or so. Do you put it closer compared to your retractor just because it's bigger?
Yeah, about, 3.5, 3.5.
Okay.
Usually, though, I mean, just generally 3, you're going to make the patient aphakic anyway, so 3 millimeters is good.
Because I always worry about like these bigger instruments, and put it into the eye, like basically radializing the sclerotomy. You said that happens before more often with like the 20 gauge or the bigger instruments that you can just, is it that you can just radialize across the?
Well, it's rare. I mean, it rarely happens. I've had it happen maybe twice over the years. Or generally patients who had multiple operations, the sclera was already, damaged and thin. And you'd make somebody's had previous surgery and you've made a new sclerotomy adjacent to an old. And I've had them rip into they'll rip into the old sclerotomy site. I had one that very staphylomatous, thin sclera, had multiple surgeries, and we were cranking the eye around, with the sclerotomies, and really working in the periphery, pushing and pulling, on the sclerotomy sites as we were moving the eye around, and it tore back. Oh God, it must have torn back 5-7 millimeters directly posteriorly. And that was really hard to repair. I mean, the sclera was just so thin and wispy that it's really hard to repair that. We ended up putting a patch over it.
Okay. Did it rip into the retina posteriorly? Yeah.
I guess on the vein of frag, I had a question. So in some cases, this wasn't one of them, but visualization is limiting and you're doing lensectomy. You get all these small pieces of lens material. I usually just kind of wait for them to settle down into the most dependent position to be sure I'm getting all the residual fragments. Are there any other tricks to kind of being sure that you get all of those, very small nuclear chips and fragments, especially if visualization isn't optimal?
One thing you can do. What do you get them with?
Well, when they're small, I usually switch to the cutter, right, because the fluidics are a little more controlled. And
now, what you can sometimes do is just go in and suck them in, even in 25 gauge. You can sometimes go in and kind of suck them in, and then take your light pipe and just kind of jam it with your light pipe, and it'll sort of break it up, and then it'll be aspirated. There was a time. You don't have too much problem with these obstructing, but there was a time, and Chris may remember this. There was a time back in the old Ocutome days when they had a problem with there was some sort of narrowing someplace within the cutter of the tubing. There was a connector or tubing or some sort of connector in there that was narrowed, and you would try to aspirate lens material, or it really even many things that like if you had fibrous tissue that you were cutting, it would obstruct the cutter, and you could get no flow through it. and you'd have to take the thing out and back flush it. And sometimes if you could back flush it, you'd see whatever it was, you'd flush it out. Sometimes you couldn't even flush it out back flushing it. You'd have to get a new cutter. And we complained and complained and complained to Alcon about it. And they finally they fixed it. But this was with 20 gauge. And
Well, it wasn't unusual to have 4 phragmatomes given all of those failures. The technology today it's incredible compared to even 15, 20 years ago.
yeah, did you have that problem where the vitreous cutter would obstruct with either lens material or even fibrous tissue?
Oh yeah, absolutely.
Yeah,
Yeah.
that was interesting how that would happen.
Somehow I still have that once in a while. It's not common. Once
Rare
in a while.
now.
Yeah, no, not common. Right. Once in a while, we had to take it out and get a big syringe and flush it out. And I think I think you may have to keep it at a higher cut rate, especially when you're dealing with residual nuclear material. If you're trying to eat the nuclear material with your cutter, because the cortical material it'll suck in, it'll be like slushy kind of, but the nuclear material, um, sometimes if you have a bigger chunk and you try to aspirate it with your cutter and you jam it in and somehow it makes its way into the cutter. I think
Cece, what cut rate do you keep your cutter at when you're trying to eat nucleus?
I don't do it. I don't do any different cut rate than I normally do. But I think you just have to keep it at a reasonable. I used to like really slow it down, like crunch, crunch, crunch. But I think it ends up potentially making a big nuclear frag, a nuclear material that can clog up somewhere in your tubing or somewhere there. So I just keep it fast and I just cut. Sometimes it's not that efficient, but I just keep it fast, but it'll cut into smaller pieces.
That's sort of like the traditional teaching is you slow it down.
Yes, traditionally you slow it down, you get a bigger chunk.
What happens is the cycle time slows down, and so it stays open longer, and you can sometimes with something that's hard that doesn't mold easily.
mm,
Mold doesn't mold easily at the mouth of the cutter. Uh, if you don't slow it down, it can't mold enough to get in to be cut, and so the cutter will just keep.
oh, it'll do
skimming.
like the micro because I guess it's probably a bigger issue with the accuracy because you're relying on that spring to open back up the cutter, and then the faster you go, the smaller the
Yeah.
port opening is.
Yeah.
With the Constellation, I think it's a little bit better. They have that dual pneumatic, so it opens close. The cut rate doesn't slow down. I guess the fellows haven't experienced the accuracy. What happened when you go really fast with the accuracy is the spring, because it's a single pneumatic, so you're closing and then the spring is opening back up. So when you go really fast, your spring doesn't have enough time to open all the way back up before the next closure. So your port opening becomes smaller and smaller as you go quicker on the cut rate. That's why we have like these so-called the 3D vitrectomy, or like where you slow down the cut rate as you increase the aspiration.
Anthony, sorry, I joined late, but is this the case that we did the other day?
No, this was a lensectomy and Yamani that I did in my first year with, I think Dr. Lin was there, yeah.
And so was it with you that we used the phaco probe to remove the lens, the drop lens last month?
Yeah, we did
You
that.
did
That
that?
was a nice trick with Sam, I think, helped us with that trick.
Yeah.
Yeah, I don't know if you guys,
Yeah.
Chris and Cece and Gary, I don't know if Pat's on there, but
With the
using the phaco probe, what would make you use a phaco probe over the frag?
before we used more because somehow the old frag, I think especially the Bosch and Lomb frag that we had, just wasn't very, like when you have something really dense, it takes forever. It's just not very efficient. So sometimes we get dense nucleus. We'll just open up a phaco machine and then just take off the sleeve and use the phaco. But I find the Constellation one, it's pretty good. The frag it's much better than at least better than the old Bosch and Lone with the frag we had. So I haven't used the phaco probe much. In fact, the only times I used the phaco probe for fragging was when we're doing phaco and we need to frag.
It was a little more efficient, I think, than the I believe we used the Centurion Phaco.
I suspect
It was pretty nice. Yeah, it was really efficient.
yeah. Well,
Hey, Chris, have you,
Yeah.
have you used, do you do Phacos?
No,
I'm not
I
I'm not talking about vitrectomy, phacofragmentation. I'm talking about phacoemulsification of the lens, for cataract surgery.
no, I've never had to.
I would be way out of my league if I had to use the.
Yeah. I feel that when I use the fragmatome, that I use the modes, the two different modes. I go with a fixed mode to start for the nuclear material and then the linear mode after that. So I've never had to resort to that. But yeah, I probably wouldn't know what a phaco emulsification is.
I wouldn't know how to use the foot pedal.
it's actually, I think, the same as these. Well, I guess it depends on how you set it up, because I think there's some where you can set it up where when you step on the foot pedal, like our frag, where you step on the foot pedal, it's just aspiration, and then you have to kick it to turn on the frag. I think the current setup we have is where you step on it halfway as aspiration, and then you could feel like a little notch kind of thing, and then afterwards it starts phacoing, which is my setup on the Constellation, on the vitrectomy machine. Is kind of like that. Which
One thing I'd always do with the fellow is I'd always have the fellow practice and be completely aware of when it was fragging and when it wasn't, so they could suction the lens, pull it up away from the retina, and then engage the fragmentation. Because once again, if you engage it when you're close to the retina, you don't even have to be against the retina. If you're close to the retina, you're going to end up with either a retinal damage or a big tear and a lot of hemorrhage, one or the other.
I'm so sorry, guys. I have to jump on my 5:30 meeting, but Chinwe is going to present a very late night, long 4-hour long case that she'll condense in a few minutes.
okay.
Thank you.
Okay, see you, Deepa.
So this is going to be a long conference, sounds like.
All right, Anthony, go ahead.
All right.
The configuration of this pigmentary change in this eye is really interesting.
Yeah.
I think it
Do you?
looks
Sorry.
like you got a retinal detachment.
Yeah.
I think this had a retinal detachment that's left all this RP atrophy and clumping. That's what it looks
That
like.
makes sense.
That's what I was thinking too, but no, I can't really say no to Anthony's theory either. That just a lens bouncing around. The lens is really loose, but I don't know.
No, that's not going to do that.
Oh, okay. I just couldn't
No
say
way.
it looks like a retinal detachment that's spontaneously reattached.
Yeah, I think that's what happened.
Yeah.
What it looks like to me.
Well, I thought my theory was more exciting, but yours is probably more correct. So we'll go with that.
I mean, I've seen people with dislocated crystalline lens, even calcified ones for years, and it without doing any retinal damage.
Okay.
You're not going to get that kind of retinal damage from a lens, a crystalline lens bouncing around. Plus, this one was not even calcified.
Right. Okay. So it's making the paracenteses kind of in as ergonomic of a position as possible to help later with the docking of the haptics, and then make and expand a main wound. You can see now that there are new marks for where the sclerotomies will be at 2.5 millimeters back, or I'm sorry, 2 millimeters back from the limbus. And then Dr. Lin taught me to make a nice little pocket of viscoelastic to make some space for your leading haptic to kind of control where that lands in the inferior anterior chamber angle. And that way you know where to find that haptic later with your max grip forceps. So the goal is to try to grasp it near the end so you can control it, and you have like essentially a right angle off of your max grip forcep, which is most ergonomic to be able to dock it into the 27 gauge needle. So there you can see pretty much a right angle where you're able to place the haptic into the needle lumen. But you need enough space to do so. So you can't just grasp it right by the tip, because then the haptic won't get any purchase into the needle lumen and won't actually hold there as you let go with the max grip to kind of walk the dog, or just walk it back into the lumen further and further with each pass. So again, yeah, letting go, regrasping another couple millimeters, pushing in. I have found that if you grasp it too far, I found the hard way one time, that it's more likely to bend the haptic. So I usually try to grasp like real short distances from the needle. And then another thing you taught me, Dr. Lin, is so initially it's much more easy to manage and handle that needle if it's attached to a syringe, but then at this time separate it from the syringe so that you can just let it hang freely. But it's important to not attach the syringe to the needle too securely or too firmly, because then you won't be able to release the two in a controlled fashion. And then here you have to handshake the trailing haptic to the max grip forcep. So you go in with here Kelman McPherson through the main wound, and your max grip through the now the left-sided paracentesis. And I don't think I even knew that you were doing this, Dr. Lin, but you prevented having iris prolapse at this step by clamping the infusion line. So then I was able to hand off the two without burping out a lot of fluid, and with positive pressure that would have pushed the iris out of the main wound.
It's interesting. That's just what I was going to ask you.
Mm-hmm. And then here too, try, I guess I was lucky that I grasped the trailing haptic at a pretty good angle, kind of near the tip, and was able to feed it in. And then at this point, I can basically externalize that trailing, that second haptic, and grasp it once it's visible with any forceps, and then just take that opportunity to quickly flange it. And then you can do the same with the first haptic that you had externalized. And here I really tested the strength of my flange by pulling the optic probably a little, or pulling the IOL probably a little more firmly here than I otherwise would have, but it just, fortunately my flange was big enough that it held put. And then, so again, created the flange on the second haptic, and then just kind of reposit it. The sclerotomy. And then his actually looked pretty nicely centered, especially once the pupil came down. It's a little on the nasal side, but here I have a diagram I made that shows kind of where it seems to work to place the main wound in the paracenteses and the sclerotomy plan sites. This guy, so I was looking back in his record, he came back just for, I think, post-op day 1, and he had went from hand motion to 2200 uncorrected, but still had some corneal edema and then was not seen again. So I think that means he's seeing 2020 now. But anyway, yeah, that pattern was interesting of the chorioretinal scarring, and then it's just a nice straightforward Yamani, I thought, to show this for this conference. And then I can share this diagram, and people can edit it too. I don't know, Dr. Lin, what you think about the location of the paracenteses and main wound and other details on this.
The key is this left paracentesis, the one on your diagram, this left lower one.
Yeah.
Yeah, that one you want to cheat. That's a good position. You want to cheat as close to 12 o'clock as you can ergonomically. You know, it looks like there's only like a couple of steps to this, but this is such a hard technique. Every down to every detail you have to pay attention to, and there's a place to grab for every single detail of this. If you don't get it right, it messes up somehow. The one subtle thing that Anthony mentioned was clamming the infusion before handing off your second instrument, because what happened, and not every time will it mess up, but there's potential, and you kind of learn every detail you learn it the hard way, that every detail to pay attention to. If you don't clamp the infusion, the iris comes out and it actually blocks off it covers your haptic, and you couldn't actually do a handoff. And then you end up having the whole lens fall into the vitreous, or the trailing end falling to the vitreous. The leading haptic, when you're feeding this in, it's important exactly how much to grasp. You grasp it too close, you can't actually get it into the hole. You grasp it too far, you end up either it either bends too much to get it into the needle, or you can potentially bend the whole haptic. The angle that you feed it into that needle, if you do it too perpendicular to the needle, you can even make a little wedge in the proline from the edge of the hole, because the actual hole on the needle, or the bevel on the needle, is actually sharp. So you can actually make a tiny wedge on the haptic, and you can get it into the needle. The location, the leading haptic is always easier to put in than the trailing haptic. And the trailing haptic, and yeah, you notice a sudden relative hypotony for a little bit, more so just to prevent the iris from prolapsing. This angle, I mean, this is the best angle what Anthony has here, but getting to, grabbing exactly this angle, it's critical where you put your paracentesis relative to the IOL. And then there's a lot of subtleties, such as, you notice we externalize one needle first and then cauterize it before doing the other one. Because at the beginning, if you look at Shin Yamani's original video, they pull both at the same time. And what happens is once in a while you do that, one side will come out and the other side will pop back into the eye. So that's why we always kind of do one side and then the other side. You can't, well, you could, but it's going to be a lot harder if you try to just do one side, take it out, and then try to put it into the needle on the other side. Your angle will be completely wrong. That's why we do this, put it in the needle and let it hang in the anterior vitreous. But this is a tough technique, even though it looks like it's, when it goes smoothly, it looks easy. But there's too many variabilities, too many places that can go south.
And don't worry, my next video, I have a video that
Fellow was doing it.
Sorry, what was that? Couldn't hear.
I said it looked pretty easy. A first-year fellow was doing it.
I have a first year fellow video that shows you all the things that CC mentions that makes it incredibly difficult for you.
Probably about 4 to 6 scenarios that can go wrong in this, that can go south in this, that you need to know how to handle to be able to pretty consistently put this in and pretty consistently get out of trouble if trouble hits you. One we mentioned is when you're putting in the second haptic, the iris comes out and plugs the wound. That's one situation. And the workaround with that is to put some viscoelastic in the wound and clamp the infusion when you hand off, and then turn it back on after you do the handoff. But there's a couple. Sometimes you inject the lens, the whole lens falls into the vitreous before you even got a chance to grab it. Then it's an IOL rescue almost. Not fully, but what you do is you manipulate the trailing haptics. The trailing haptic is still outside the eye, and you can actually control the IOL pretty well by just manipulating the trailing haptic. I think Brett will show some variations.
Yeah, I keep Yamani very interesting.
Dr. Lin, I wanted to ask you, I have a patient who had remote history of trauma. He's like a martial arts instructor, and he subsequently had his phacoemulsification done. There was some, zonular dehiscence noted intraoperatively, and so they ended up putting sulcus IOL, and I don't believe there was ever vitreous loss, and there wasn't any note of PC rupture, and that was like 5 years ago or so. And then now he came in with acute vision loss and has a dislocated IOL. So it's sulcus IOL. It's pretty significantly dislocated. So it's just half into the visual axis, and he has monocular diplopia and so forth. So have to do something about it. The bag looks totally intact. So I was thinking Yamani would be nice, but I'm assuming that the needle entry is going to come. Do you think it'll come in posterior?
Anthony, I did this case this morning, and I have a video of it.
Oh, good. All right, perfect. I'm glad you did that for me, because
So we can talk about it and how I did it and what I learned.
Yeah, okay.
All right, very good, very good. I'll set you as the host here.
Yeah, so I actually have 2 videos. I wasn't planning on showing the Yamani video, but I did it this morning with Dr. Chapman, and it ended up being pretty nice. And then my other video is a Ozurdex that's in the AC, which I also learned a lot, and the 3 tries that I screwed it up before I got it right. Let's see. Nope, strong one. I was studying for boards. This one. Can you guys see my screen? I remember last time I was having trouble sharing.
I see it.
Okay. All right, so retina surgical conference. So this is a gentleman who came in. He noticed he was noticing this white thing in the front part of his eye. He had an Ozurdex placed 6 months ago. Vision was down a little bit. Pressure was okay.
His cornea was still okay.
Cornea was still okay. He had been there for about a week. We'll get into like a tiny M&M at the end for like how this happened, and then a couple things. But he actually had cataract surgery 1 week ago, and he told his cataract surgeon, and his cataract surgeon never actually looked at that eye. But that's a different story. I already spoke to that resident personally about checking both eyes postoperatively, especially when your patient tells you. But also we put an Ozurdex in an eye that had a Yamani, which is another story to talk about 6 weeks ago, which is how we got here in the first place. So I started out with doing the Dr. Lin DSEC dance to try to position it more centrally. It was not working for me. And he's like, "Why are you punching me in the eyeball?" So I just thought I would manipulate it intraocularly. So I tried to get on access. I made 2 paras because I originally thought I was going to be able to inject BSS on one side and try to burp it out the other side. That was my original elegant technique that I thought was going to work, which you will see does not work well for me. So I try to capture it in a little visco ball and try to kind of nudge it more into the center here on line with my paracentesis. And A couple things I learned: really don't touch it. It's incredibly fragile. Just try to float it in your viscoat. And so here I don't have good positioning, but I'm like, I'll just try to create a stream of BSS and viscoat and inject BSS on one side and try and get it to burp on the other. It does not work very well. And so now I'm repositioning it. I actually get it kind of on axis where I want it to be, and then it gets kind of nudged out of position, unfortunately. And so now it's nudged out of position, and now I break it. So I'm like, this is stupid. I'm just putzing around in the anterior chamber and I'm causing problems. So at this point, I just immediately decide to enlarge my para, cover the thing in viscoat, and just burp it out, which works a heck of a lot better rather than kind of putzing around and touching it and yada, yada, yada. So I just cover in viscoat and burp. And then I'll do the same technique for the second half. So again, now I broke into 3 pieces, but I just keep putting it in the visco ball. So it's in a visco ball and I just keep burping. And it comes pretty easily. And so for the like 5-10 minutes I spent putzing around, I was able to get it out in 30 seconds once I switched to doing it this way.
Yeah, that's the key. You actually have to burp. It has to have an outflow for it to come to your wound.
Yeah, so I had to make my para a lot bigger. I was trying to be like fancy and keep it clean.
It has to be big. It can't be like
and then
2 millimeters. It has to be bigger.
Yeah. And then I just rinse the AC out with BSS, ensuring I get any particulate matter from the Ozurdex out. And then just suturing the eye up at the end. So I learned a couple things here that was really important. Don't touch it because it will break. It's very fragile, and then it just starts to disintegrate. So if you just immediately make a big para, capture it in a ball of visco and burp it out, I would have saved myself, a little bit of 5 minutes of a headache. And then, we need to be cognizant about this. If you can see right here, I don't know if you can see my cursor, but there is a little blue haptic. This patient does have Yamane. So this was a patient with refractory DME. And it sounds like from the note, a lot of this was discussed with the patient, but he was very adamant. And so an Ozurdex was done. And then the Ozurdex ended up in the AC. So it is a very real problem that does happen. And I think we need to be really cognizant about that. And then post-op day 1, his cornea looked pretty beat up. I haven't seen him since. And then, but
once you lined it up, we think we can just inject and catch it in the ball of visco and it'll just kind of flow out. But you actually have to have a lot of outflow. You have to burp it like what you're doing. You have to burp it quite a bit while you're injecting.
I thought it was going to make it a lot more elegant, but you like you're saying, Dr. Len, you just have to do that, and that ended up working a lot better for me.
Yeah. What actually brings it out may be more the outflow of the viscoelastic rather than the actual catching it in the ball of viscoelastic.
Yeah, it's like it's just trapped, and as the visco comes, it just pulls it with it. So that was a good thing to learn, and I learned a lot during that case because I kind of made it up on the go, but it ended up working pretty well. I had an idea because I talked to you of what I needed to do. But
now, one way or another, it'll come out, but it's just you want.
Yeah, and then the next time it'll look a lot better.
Yeah.
And then, so that was kind of a simple case. So then I did this case with Dr. Chapman this morning, which actually ended up being exactly what Anthony was talking about. So I just edited this video real quick today. So real quick, he has a history he's in the military, has a history of a shrapnel injury down here. Though on actual vitrectomy, the retina looked intact. There was nothing funny down here. So he has kind of this filtering bleb conjunctival scar type lesion that we had to avoid during our placement. So that's why we have this funny setup going. So just a quick vitrectomy. Everything in the back of the eye looked nice. He was actually already vitrectomized previously. He had a 3-piece in the sulcus that had gradually shifted out. So I kind of made my paras as if I was going to rescue this. And then I immediately just took my Kugelin and positioned this to move it into the anterior chamber. So by moving it into the anterior chamber and having both haptics in the AC, I knew that it was well protected and stable. So I kind of just pop it here into the AC. I know it's stable. And now I'm just going to get, now I'm going to get the second haptic into the AC. Now I use my retractor and I just clean up any remnants of the bag just to ensure we don't get any scarring on the ciliary processes. So I kind of just pull away the remnants of the bag. I'm able to get most of it. Most of the bag inferior was lost. So now I'm rotating it to try and get it in some semblance of a position where I can get a good grip for Yamani. So I'm using a Kugelin to position the haptic while handing off to myself because I didn't have a perfect angle because I didn't just inject the lens straight across. The lens was kind of rescued from the sulcus. But for my first haptic, I'm able to get a pretty good, normal type grasp. It's the second haptic where things get a little interesting on this technique. So just kind of tilting the needle, using the back end of it to feed myself after it bounces out a couple times. And then I end up, as I'm rotating this and trying to get in good position for the second haptic, because I'll pause this here before I show what happens. So I end up trying to get the second haptic. I end up dunking it into the vitreous, just trying to get a good position and grasp. If you can see, the haptic is like this. Generally, for the second haptic, you're able to come on the outside and get a good grasp to feed. Unfortunately for me, because I'm coming from the inside of the eye and the haptic is already inside the eye, I have to come from the inside to try to get a good angle, which involves using a Kugelin to kind of position it while you're grasping it. I hope you all appreciate the graphics there of my hand, but in doing so, I ended up dropping it into the posterior segment. So the leading haptic is fallen, and I was repositioning the needle I was using the needle to reposition the lens while trying to grasp it from the posterior segment. And the needle ended up loosening and coming out, essentially. It was almost out. So I just took the needle out and scleral fixated the first haptic, to make my life even more difficult as we move on here. So I'm able to get this haptic fixated. Generally, I'd recommend not doing this. It makes it a little more difficult. And so again, kind of similar. No, what happened? Sorry. And so again, I'm using the Kugelin to bring the haptic down and show myself where I'm trying to grasp from, so I can just have a better view, because otherwise the haptic is driven into the angle. So I'm able to get an okay grasp. I'll show it in the center here. So as you can see, I'm on the inside of the curvature, whereas Anthony was able to grab on the outside of the curvature because it was coming from the outside of the eye. So this is a really tough angle, and especially with the MA60s where they really do bend. So my goal is actually to be able to nudge it a little bit further this way with the Kugelin, but I was having difficulty and I'd already dropped it twice, and I was concerned that I was starting to get a kink. So I was just going to place it with this positioning. As I kind of get it into position here and dunk it behind the iris and have my needle. I really am going to kind of crank my needle and do this just under the edge of the iris, so I can try to get the best positioning as possible, which still isn't great, but given the setup. And you'll see I get it in and I have a little curve in the haptic, which the MI60 can handle a little bit, but it does not take a lot. So really I can't go any further than that without risking bending the MA60. The Zeiss Lucia lenses can take a lot more and they can bend a little bit further and they're more forgiving, but the MA60s aren't. And essentially I'm able to get this one out. You see there's the end has a little tiny kink to it, but overall the haptic's in really good condition. And I was able to refixate the lens that this patient had in the eye without having to do a traumatic lens extraction. I evaluated the patient's refraction. They were about -1.5 before surgery. So the expectation of moving the lens back, they're going to have a tiny hyperopic shift, maybe a diopter or so. So I'd expect that I'm still going to leave this patient about a half diopter myopic. So I shouldn't have a terrible hyperopic surprise after surgery. And the lens was pretty well centered. and I didn't have to cut a lens out and put another lens in the eye.
If you have a lot of trouble with that Kuglen to move it, I use a Kuglen because a lot of times I can get by with a Kuglen. But sometimes, like in these very difficult angles, you can just open a second forcep. You can open a second max grid. Usually that makes your life a lot easier in terms of
Okay.
the IOL and put it into a position you want. Kuglen is just a lot of times we can get by with it. I mean, in the sense that you can, but
Yeah,
if it's dropping back and forth, you might as well just open a second forcep.
Yeah, that's a good thought. I do really like the Kuglen. We were still able to get this case done, and I think we were done under like 45 minutes, a half hour or so. So we weren't sitting there too long with it, but it might have helped just preserve the stability of that second haptic a little bit.
Somehow, Phil Liu actually does his like this, where he takes out one, cauterizes it, and then feeds the other one. So there must be a way to do it that's not as true, that's more straightforward. I need to talk to him how he actually does it, because everybody else that tries to do one and then the other side doesn't do well.
Yeah,
acrobatic.
Yeah, the positioning of the the second haptic is really where I have difficulty. If you lose the good positioning, like the first grass that Anthony had, where he had essentially perfect positioning on it, if you lose that grasp, now you're on this kind of like inside loop positioning right here. And this inside loop positioning is really difficult to work with, especially with the MA60s, where there's a high risk of kinking the haptic. So as you saw, I was really kind of had the needle down here, and we're working almost under the iris plane to try to get the best possible angle.
There's another thing you can do is the max average opening. You put it in this orientation. You put this paracentesis where that bleb is, around where that bleb is, and you come from that side. So your approach angle is the same as your first haptic in terms of you coming from that side. It's problematic when it's the right eye, because that's where the nose is. But if it's the left eye, that's in these situations, you can just push in the one that's already flanged, the first one. You can push it in, and you'll rotate the eye in a pretty comfortable position for you to hold it if you're just coming from around where that blood is, that angle.
Okay, that's good to think about too. I just tried to stay away from this bleb. Yeah, so this is left eye. I just try to stay as far away from the thing as possible.
Yeah, this one's difficult.
But it worked out well. Didn't have to explant it, so I'll take it.
That was pretty cool. That was a good case. Another thing you could consider is doing like a trocar assisted too, where you put in like for that trailing haptic, you could put in a 27 gauge trocar, and I guess if you had to, you could use a 27 gauge forcep and just grasp it by the tip and then pull it out. I've only done that once, but
I haven't tried that yet.
Like that, yeah.
Good idea.
It's a cool case. Thanks for blazing the trail for me for my case.
Yeah, you're up tomorrow.
All right, Chinwei, you want to show your video, Chinwei?
Yes, let me share my screen.
Hey, Cece, just one last thing that I'm sure everybody here knows it by now, but when we have to remove these implants from time to time, that you really have to go that night. I mean, it's tenuous anyway, but by the next day it's terrible. So don't ever kick it to the next day. I think I just want to say that for peace of mind more than anything. But
yeah, we took that one right after clinic that day.
And my first learning curve was trying to do it in a small little surgery room in an outpatient clinic, and my first mistake was not doing a full peribulbar block. Instead of doing, I did a subtenon's cannula, and these patients have quite a bit of pain with manipulation of the iris and so forth. So, I learned that I had to keep expanding it, and no amount of rubber tube suction or manipulation. You only got 3 pieces, Brett. I've had 7 or 8, but I got them all.
Okay.
Okay. So my case I did with Dr. Yoganathan, like she said, We had a 78-year-old female who was status post complicated cataract surgery with a 3-piece MA60 sulcus lens placed. On exam, she was 20/50, 20/40. Pre-op exam was significant for a dislocated sulcus IOL that was displaced inferiorly. So we did use a trocar assisted Umani for our case. And so we placed 27 gauge forceps about 180 degrees apart. And then we created a paracentesis, did a bit of a vitrectomy, and then freed the implant, the vitrectomy around the implant. And our plan was to rescue the implant and to suture it with the Umani. And so then we lifted the implant into the anterior chamber. When I was reviewing this, one thing that I think we should have done is really make sure that it was stable on top of the iris. We put the proximal haptic up on top of the iris and fed it through the 27 gauge trocar, as you'll see. And so we did use 2 max grip forceps. And so we externalized the haptics through the proximal trocar here. And so instead of, like Dr. Lin was mentioning, that typically folks don't secure the flange, the haptic first. We did do that, which is a good learning point. So we secured this haptic first, and then as we did that, the IOL fell back up. So then we rescued the distal portion of with a little more vitrectomy, and using forceps, we brought the IOL back into the AC, the distal portion. And so. So lifting the IOL up. And externalizing it once again through the 27 gauge. There's a lot of tension on this poor haptics. And so like Brett said, the MA60, they don't take tension well. So that was quite a bit of tension on the haptics there. We secured that in place there. So afterwards, we were try to center the IOL and try to clean up the anterior chamber and clean up the hyphema, and make sure that the centration of the IOL was appropriate, because with the placement it was a bit off center, and so here we are trying to recenter and clean up the AC of this viscode and of the hyphema. And as we were doing that, unfortunately, the haptic broke, the proximal haptic broke. And so it's not exactly at the optic haptic junction. I thought it was at first from my memory, but it was a little distal to that. And so now it's hard to see on this video, but the haptic is broken here. So then we try to sclerofixate the haptic. And so we're just coming up with different ideas as far as ways to secure this proximal haptic here. I don't know if, so it's broken somewhere here. This is secure. And so we're trying to perhaps feed the suture underneath the iris and externalize it and sclerosuture it in some way. And we tried several different ways and we attempted, and we weren't able to secure the secure this haptic here. So so here we're trying to make a pass, and
you don't want to do that. It's probably easier if you put in the needle on the other side of the sclera, put like a 27 gauge needle in there, and then you can lock it in. It'll be a lot more accurate coming out. You know
Okay.
exactly where that thing is coming out.
And then as someone who has personally lost a lot of second haptics in the back of the vitreous cavity, I've had a really good luck with putting the Kugelin under getting the Kugelin under, lifting it all, doing it all from the AC without the biome, lifting it up with the Kugelin, and then coming in with my max grips across and grabbing it, and then putting it back in the AC and just restarting fresh, rather than trying to position a grab in the vitreous, because I have broke, God knows how many haptics back there. But just repositioning it back into the AC using the Kugelin to like float the lens up behind it, and then grab it and put it in the AC, it really allows you to just reset and restart. So that's what I like to do, because inevitably I seem to always drop the second haptic.
In retrospect, yes, I wish that the IOL was in the AC and, centered there before we started. And I wish we didn't secure and flange the edges before. So we tried to secure that haptic, but we couldn't. And so we decided to just explant the IOL and put in an AC IOL. The patient's doing fine. She was actually seen on the 16th, and she's like 2030 or 2025, something like that. But it was a good learning case, definitely. So I was just looking at different ways to kind of secure the a haptic if you have to rescue an IOL. And I saw this interesting technique called the cow hitch sclerosuture, where you basically create a scleral bite, and you externalize the haptic, and you tie it with this knot called the cow hitch knot, and you secure the haptic that way, and then you're able to kind of secure the haptic onto the sclera. So I don't know, it was an interesting, I mean, the trocars, I think trocar assisted Yamani, there are a lot of positives to it. And I know some people really are advocates. They feel like it helps secure and helps dock the IOL better. I think it was a little harder to manipulate with the trocars. In my opinion, I've done it both ways. And I think, in my opinion, it was a little difficult to manipulate the IOL with the trocars. So.
The cow hitch one, we've done a variation of it. Instead of taking it out to do a cow hitch, we actually did the whole cow hitch in the eye for this.
Oh, interesting.
It's you can do it in the eye. And we use a Gore-Tex suture actually.
Oh, okay.
For the cow hitch, and you just can feed it in. You need two forceps, but you can just do the whole cow hitch in the eye without taking it out of the eye.
Interesting.
This was a dislocated multifocal lens, a dislocated symphony that we just, Max Savage actually has the video of basically doing a cow hitch to refixate the symphony lens.
Interesting.
Intraocular, but we just did it intraocularly. Once your haptic break like that, I think you gotta take the IOL out.
Take it out.
There's no great way of fixating that way.
Yeah, we tried for a long time.
You're going to end up causing more trauma, try to refixate it,
Yeah.
than just taking it out. And frequently you can just put in a new fresh IOL.
And start again.
Yeah, usually we just take it out. If haptic break or something, we just cut it in half, take it out, or cut it, like a Pac-Man, take it out, and then put in a new MA60, and then we'll just refixate it.
Mm-hmm.
I don't think I've ever had to take out two IOLs, but occasionally you do have one that breaks, because usually it's the ones where it's a sulcus IOL that dislocates. You try to make it minimally traumatic, so you try not to take it out, but sometimes it breaks.
That was another, I mean, I think Dr. Yoganathan and I were talking about, I mean, it's nice to be able to rescue it, like Brett said, but we were thinking that maybe we should have just started, especially because it already was dislocated, and it seemed like it had some trauma being placed initially. We were thinking that maybe we should have just taken it out and started afresh and tried to.
Interestingly, we had this little poll that if you had a dislocated like this situation 3-piece, actually most people actually just take it out and put in a fresh IOL.
Mhm.
I think we generally try to rescue it, and usually pretty successfully we're able to rescue it. I just feel like at least give it a try. It's rather than a big corneal wound potentially damaging the iris when you're taking it out and putting in a new one. That if you can
Yeah.
just fixate it, a lot of them, I think majority of them actually go very elegantly, and you can just refixate it without much trauma. But what I actually really like is the AO60, the Gore-Tex. That one, there's a lot more step to it, but there's a lot less room for, a lot less likely to mess up.
Yeah.
If you have an eye that, especially the eyes that boxers and people that's potential to get trauma. We have one kid that self mutilates or he hits him, basically he punches himself, and then he knocked both of them in. But we did a Yamani on both sides. I think he knocked both of them in, and it's not from the, one of them is from the the little bulb got knocked in. The other one, you have both bulbs still in place. The whole haptic optic junction broke.
Oh, wow.
So in those cases, I think if you can suture like actual Gore-Tex suture, you're going to be a lot more stable.
Chinwei, I think you've probably followed the technique to how they described it, because I don't think you can do it any other way than to flange one at a time, because you don't have the needles to let go of and secure the haptic. You basically would have to flange it. So it may not be as good of a technique as the kind of modified Yamani that we do.
When do you think that the haptic actually broke?
I mean, I think the tension of securing it and pushing it through, pulling it through the trocar definitely weakened it. And then I think when we were cleaning up the AC, I mean, I think it was already pretty weak. And then cleaning up the AC and kind of repositioning the IOL was the final straw that broke it. But I think pulling it and securing it through the trocar put a lot of tension. I mean, like Brett said, the MA60s, they're known not to be as strong, and so the tension that we were it was that using to pull the haptic through the trocar, I think that really weakened the haptic there.
Now, when you were cleaning up the AC, it didn't look like you were putting much tension on that lens. I mean,
Yeah,
pretty.
I think it was already pretty. Yeah, I think it was.
It broke at a curious place. I wonder if the vitrector cut. Actually, the vitrector doesn't cut through these. We tried it. It doesn't. Yeah, it looks like when you're pulling the second.
Yeah.
It's on a lot of tension.
Yeah. Let's see if we'll play again. Seems to be thinking.
It's a lot of people favor these techniques. The one where with the a 3-piece IOL and flanging, but it's a steeper learning curve than the Gore-Tex suture technique. The Gore-Tex is pretty reproducible. It's occasionally you may want the string want to tangle, but it's not hard to untangle it. These, sometimes you break a haptic, sometimes you bend a haptic. It's a little more. There's different situations that can go wrong.
Yeah.
Do you know if we can order the hydrophobic version of AO60?
Is there one?
They're developing one, and I think, Dr. Chapman, did you say if you saw that on in the Duke text?
Yeah, I was showing everyone it's in the new Duke vitreoretinal surgery manual, and
We
yeah,
can look into it. I mean, that would be very good if you
I
could.
can't remember the number, but I know somebody photocopied it and was going to try to hunt it down.
Oh, that would be very good. That likely will get rid of the crystallization problem.
I have the photo on my phone. It's the MX60 and Vista lens by Bosch and Lam.
MX60. Okay.
MX60 and Vista.
Okay. That would be good if we're able to.
There was another, and
What's it made of?
It's acrylic.
not-
I don't have the photo of the second page.
Is it
Yeah,
silicone?
I don't have the manual for the reference, but it,
I
we
would-
can find that out.
Let me see if I have.
I imagine it's probably acrylic.
there was an Invista that was different that didn't have 4 eyelets. It had
Two.
kind of 2 eyelets.
People
But
watch those, yeah.
I'm presuming this is a different one. Yeah, it would be nice to have the exact same AO60 style with hydrophobic material.
That's the most stable lens once you put those in.
So on page 165, 166 of the Duke Manual of Vitreoretinal Surgery, it's the MX60. It is the lens, I think, that has, it's the lens with the 2 haptics, not the 4-point fixation. So it has the one hole on each end in the haptic optic
That's a
junction,
little different. Yeah, that's
and it's hydrophobic acrylic lens.
yeah, that's a little different. That one only has 1 hole on each side by the haptic optic junction.
Yeah, that's what this is set up as.
Yeah.
Yeah, I think you can get tilt with that.
You can
It's,
get more tilt. Yeah.
it's not as good as the true 4-point.
It says it's hydrophobic acrylic.
Yeah. Well, let me show a quick one and then we can be done. This one was actually, yeah, I think Chris Adam may have shown it. It's along the same lines. Let's see if I can find it. And it's actually just on our YouTube channel. It's along the same line as the AO60, or sorry, not the AO60, the Ozurdex removal. It's
We herein highlight a novel technique, suture fixated Utique fluocinolone implant in an aphakic patient with active panuveitis and refractory cystoid macular edema. The patient did not tolerate systemic or periocular steroid therapy. Our initial plan for a Retisert implant was not approved by the insurance company, however Utique was allowed. Due to the patient's aphakic status and concern for possible anterior migration of the implant and corneal decompensation, we devised a novel technique for suture fixating the Utique implant to the pars plana. We start by making a localized peritomy in the infranasal quadrant. The Utique implant was injected out of the applicator onto the ocular surface. We initially secured the implant with a slip knot using a double-arm 10-0 proline suture on a CIF needle as demonstrated. Additional knots were then added. The implant was grasped lengthwise using non-tooth forceps and inserted into the anterior chamber. The first arm of the suture was passed through the main wound and positioned in the pupillary axis. A 27-gauge needle inserted 3 millimeters posterior to the limbus in the infranasal quadrant was used to dock the needle and externalize the proline suture. This sequence was then repeated for the second arm. Both ends of the suture were then pulled up to position the Utique implant at the infranasal pars plana. The suture was tied down in a 3-1-1 fashion. The peritomy was closed with 6-0 plain gut suture, and the main wound was closed with 10-0 vicryl. Thank you for watching.
Chris is really good at narrating those. But that's a little different than the Ozurdex.
Most
That
important thing is just the fact that our emphasis very much is on fellow training here.
I think that's our
we want
original video somewhere.
Outstanding care in retina. We want outstanding. Who's that?
That was our fellowship, which was really good video, actually. Yeah, that UTIC one was, it's interesting. Her insurance would not do Retisert, but somehow UTIC, it doesn't even require authorization. But these actually has a solid core. It's not gonna be biodegradable like the Ozurdex. So the tubing is actually a hard material that you can actually tie onto. You can't do that with the Ozurdex, you'll split it in half.
If the patient wasn't, aphakic, like this patient,
No, I don't think it will work. You can't do it.
could you just make, could you just kind of do it like an Ozurdex and make, your 3 millimeter pars plana incision, and then kind of deliver it with a McPherson and try to just drop it off and then tie it. It might have a little more dangle to it, and then use the proline sutures to close the sclerotomy in the same way that we do in Ozurdex.
That was the
Or not an Ozurdex, you know what I mean.
That was the
Retisert,
original
sorry.
plan. The original plan was actually try to tie this whole thing in the eye. And then Chris Adam was like, why don't you just tie it outside the eye and then put it into the eye since she's aphakic?
You could still tie it outside the eye and then just kind of pop it in through the,
How do you take it out?
oh, it has to come out.
Yeah, how do you tie it outside? Oh,
So you use it, you close the wound in the same way that you close a Retisert wound with your 2 proline sutures.
you may just do the same thing, but put it through pars plana.
Yeah, put it through pars plana.
I guess you can. It'll be a bigger. You can. It'll be a
Just for a patient that's not, not aphakic.
It'll be
There was a little caveat to that.
It'll be a bigger pars plana one, but that situation has not come up that they can't insert that only UTIC in a non-aphakic. That combination hasn't come up yet.
Okay.
All right. I think that's all the videos we have. I think next surgical conference is probably the one that we're doing a combine with the one that Deepa sent out that we're gonna combine, I think, with University of Toronto.
Do we have a topic?
Yeah, buckle and buckle complications.
Okay, well, let's get some really good stuff together.
Yeah.
We're in competition with the other institutions. We've got to outdo them. Okay.
Yeah, we gotta outdo them. We gotta get some. I mean, this one, it's always tough for videos for this buckle one because it's there's not that many videos. What we did before was like kind of cases and then kind of discuss, and there's a lot more talking than actual showing.
Yeah.
Video. I have a feeling they'll have more video because their buckles will be buckle bits, a lot of them. But I think what we can do is put together some cases that actual the discussion will be clinical approach. I mean, it can also be like buckle, no buckle, how you do a pneumatic buckle vitrectomy and like.
See, I think why don't you the next buckle that you do and where you drain subretinal fluid, with your method, have somebody just video it.
Okay, we can do that.
And just get some footage on. I mean, your drainage technique is very different than Chris's drainage technique, and be kind of interesting to contrast the two. Chris, could you get somebody to video your drainage technique?
Yeah, I think that a simple iPhone could get close enough.
Yeah,
to
you can
feel.
do it with your iPhone.
Yeah.
Okay. Yeah,
I have a GoPro that someone can put on their head if they're feeling very ambitious.
You do have a GoPro.
I've got one too, Brett. You can wear it while you're doing the drainage.
It'd be kind of cool to do that.
Yeah, we can
Yeah.
do.
And then we'll show you doing that at the Toronto meeting. So
You know,
we'll
my
have a
next
camera
buckle,
with the camera.
my next buckle was actually good. I was going to use a new instrument. They designed this drainage needle for me that's a protected drainage needle. Basically, you put it in and there's a lever you push and it actually has like a blunt inner tube that comes out so that as the retina comes, it doesn't snap, it doesn't touch the sharp needle. I was actually going to try that, but we could do, but we could show that too. It's a new prototype instrument that Vortex is making. It's just basically, I had this idea that I want something to protect the drainage needle once it's in the eye. So they thought about an inner tube, a blunt inner tube.
I think it'd be interesting, just as part of the discussion, just talk about methods of drainage of subretinal fluid.
Yeah.
When do you drain? Who do you drain? Who do you not drain?
Yeah.
How are you going to do it? The various methods of doing it. I think that would make for some interesting discussion because you're going to get a lot of diversion of opinions on that. That'd be kind of interesting discussion.
Yeah. And when do you put a gas bubble?
Yeah.
There's a lot of people that just put a gas bubble in majority.
Dean Elliott never drained anybody. He just put a gas bubble in everybody.
Yeah, I remember hearing that.
It's because at Duke he had never learned to drain subretinal fluid.
Yeah, drainage, buckle, element. When do you do a radial? When do you do a encircling?
Pull up some examples. I think for that conference, pull up some examples of various types of detachment.
Yeah, I still have all the cases.
You can make a drawing. You can make a drawing of what, if you don't have a photo, just make a drawing of the detachment.
Yeah.
Of what the detachment was, and discuss the indication for the type of buckle and how you do it.
And we could have some that's got some subretinal bands, got some basically some PVR that's also buckleable that do just fine with a buckle too.
Yeah, that's there's a lot of people who have a misconception that if there's any amount of PVR you have to do a vitrectomy. That's just not true.
Right. Okay, so I will share with the fellows some of those cases we have, and we could throw in different cases. A lot of these are like by drawing or pictures, pre-op, and just kind of talk. There's not that much.
Yeah, and then we ought to think of some buckle complications, things like that.
Yeah, suprachoroidals.
Persistent shallow subretinal fluid that lasts 6 to 12 months and things like that.
Yeah.
It's kind of interesting. CC, those articles I sent you by Mockemer?
Yep.
Yeah, one of those articles, he shows these little pockets of residual subretinal fluid in the monkey. And he's got all kinds of histopathology on that. Huh. How after we do a buckle, sometimes you'll see this, when you,
the little bumps.
When you do your OCT too soon after the buckle.
Yeah.
And you see that residual little pockets of subretinal fluid. He's got all this beautiful histopathology on these monkeys where he was doing these, he was reattaching the retinas on these monkeys. He'd do these experimental retinal detachment and he'd reattach them. And he showed all these cases with these little pockets of residual fluid like we see in our patients.
Yeah.
And I thought that was really interesting that, they were describing this in the experimental animal, back, and this was 1969.
They all seem
nobody really knew we had this till we started having OCT. That we had it in humans, and it's very, very common. So
somehow they all do fine. It seems like I think Chinwei, I saw that patient, residual couple months, still got a teeny tiny bit.
I got one lady that it's interesting. She developed. She reattached. We did a buckle, reattached her, and she had a very prolonged residual foveal fluid. She's attached everywhere else. She just had this bubble of foveal fluid, and she ended up with some pigment atrophy in the macula
Okay.
where she had this residual fluid. But interestingly, her vision is good. Her vision came back very good.
Yeah, and I don't think it necessarily correlates whether it's an acute or chronic fluid, or if there's a PVD or no PVD. I thought for a while that it maybe I was doing buccal in people that hadn't had a real true total PVD yet, but I had a lady, I drained her after a year and she got better. I just couldn't take it anymore. So she made me do it and she did well, but it was very shallow, but I don't know why. So.
No, it's interesting. The pneumatics that you see with a persistent fluid don't do that well. Well, at least the one I see, where a pneumatic, everything is detached except for some macula fluid. Somehow that those, at least I had one that it went away after like 6 months, but their vision didn't get better.
Yeah. That'd be interesting. You know, Deepa probably has more experience with pneumatics than any of us. It'd be interesting to hear her perspective on these sorts of residual fluids and pneumatics. I never had enough experience with pneumatics to really understand all the little ins and outs of one of the pneumatic. I did enough of them to know I didn't like to do them.
Okay, so we should probably prepare this one a little bit earlier ahead to get together some cases since we're kind of together. So we want to.
Yeah, it'd be kind of nice if we could just sort of discuss them ahead of time.
Yeah.
Because once again, we've got to be the best on this.
Yeah, I mean, we probably buckle more than.
Actually, I'm kidding. I hope you know I'm kidding.
Yeah, but in a sense, we do buckle. I have a feeling we do buckle more.
Yeah, I have a feeling as well.
This
Okay.
is going to be the Super Bowl of scleral buckle lectures, Gary. You got to get ready. It's like Oklahoma and Texas.
Yeah,
So.
right. Absolutely. All right, everybody.
Okay, all right. Good night, everyone.
Oh, and Brett, good luck on the boards.
Oh
Oh,
yeah.
yeah, good luck,
Thank
Brad.
you.
Good luck.
Who's taking boards?
Right.
I take oral boards on Saturday.
Oh boy. You almost look
Yeah.
normal right now. How's that? I mean,
I'm barely holding it together.
I remember how anxious I was for that. So I think everybody is. It's part of the hazing. It's part of the hazing process of getting into the specialty.
Oh.
All right. Good night, everybody.
Thank you.
Mm.